This is failure to thrive. What the hell does that mean? I say got it right?
Yeah, and then just keep going.
God bless us. All right, here we go. It's not moving, Katie. I told y'all this would be exciting. All right, there we go. How about that? All right, so here's our topic. We're going to do failure to thrive, and this is more for the inpatient kind of setting. A couple of years ago, we did it where it was more for the outpatient, but this is more for inpatient medicine. And is everything all right? I can't tell if y'all can hear me in the wards. All right. All right, so here are our kind of objectives. We're going to learn about what is failure to thrive, and obviously we're going to use a new term. We're not going to say failure to thrive anymore. We're going to talk about growth charts. We're going to talk about how you like work it up for a patient that's inpatient, and our treatment strategies, which are kind of different from those that are in the outpatient setting. So one of the biggest things, first of all, I want to say thank you to Dr. Edwards and Dr. Gambrell and Dr. Norton. A lot of this stuff, most of y'all have probably seen before on the wards, thanks to Dr. Edwards and her team, teaching us all, and even my partners, about all the new terminology and the new ways to code things. So kind of what is out is failure to thrive. We use it all the time, but we don't, this is not a diagnosis, it's not a syndrome. And you've heard many of the attendings say, please don't document this, or try not to, this is not codable. They want us to be more specific. So again, failure to thrive, we can use the word, but it just realized that it is not a diagnosis. It is kind of a descriptive term. And so the new word is more malnutrition or undernutrition. And actually, a lot of the articles talk about growth faltering. And God Almighty, if I can't ever say that right, weight faltering, growth faltering, whatever. Just know that we don't like to say failure to thrive, even though we use it all the time. Early pediatric malnutrition is another kind of one of those terms that's kind of out there now. So everybody has different diagnoses, different definitions of growth faltering or failure to thrive, and we'll get over into the more important definitions. But like we were always taught in med school, that if is a descriptive term, if you're expected, your weight for age and weight for length or BMI is depressed, or like we always kind of remember, is if you cross two major percentiles. So if you're sitting there plotting them on a growth chart, you cross two major percentiles, you're supposed to go, oh gosh, I have an issue, I have a problem, now what do I do next? So again, the pathogenesis is so, in the etiology, we could take hours of talking about, the differential. So this is really just to talk about just the basics, just how to recognize that someone has failure to thrive, and that, oh gosh, when do I need to put them in the hospital versus when do I need to put them, when can I just continue outpatient management? And again, the most common cause is usually due to inadequate energy intake. So that's malnutrition, not getting enough calories. But there's also excessive energy expenditure, so that's like if you're heart disease, or defective utilization of energy. So there's three different types. And what we're going to focus on today is kind of talking about malnutrition with not enough calories. You failed the outpatient treatment. So how do you code? How do you diagnose it? How do you treat them once they get into the hospital? So when you talk about failure to thrive or malnutrition, so we kind of use those terms interchangeable. Most of our cases are usually less than 6 months of age, and this is seen kind of, we see that up in the hospital, that a lot of these are going to be little infants, and then 95% of cases are under age of 2, and that kind of goes with the literature that by the age of 2 and 3. Your brain is developed. If you're malnourished or in losing weight, that you're losing brain cells at the same time. The prevalence is, it's hard to kind of get a good estimate because everybody has different definitions, but anywhere between 2% to 10% of failure to thrive and malnutrition. We do see that it is a little bit higher in children in low-income households or children with special care needs, kids that are immigrants or refugees, or kids that are, of course, born at low birth weight. And then what we kind of used to say when I was a resident 20 years ago, we talked about, okay, we're going to admit for failure to thrive, and then we're going to rule out the organic versus the inorganic causes of failure to thrive. Well, now we no longer say that because we all say that they're all combined together, right? So it's a multiple factor deal that deals with the medical, the developmental, the behavioral, the nutritional, psychosocial. So all of this goes together no matter what your diagnosis is. So we don't want to just say, oh gosh, we're here to decide if this is organic versus inorganic. In other words, we don't want to say, okay, is mom the problem? Or is it because you got Hirschsprungs? Actually, it's probably a combination of all factors for either one of those diagnoses. So never say failure to thrive and don't talk about organic and inorganic causes. All right, a big deal when you're talking about failure to thrive and malnutrition and in the hospital setting is also, and we've heard this term before, role of social determinants of health in growth faltering or malnutrition. So what are social determinants of health? And these are big time in the literature. And these are conditions in which people live that are born, live, grow, and age. And there are significant factors in undernutrition and growth faltering. And what are those significant determinants of health? Those would be the ones listed here. So food insecurity, housing instability, energy insecurity, can you not pay the bills, poverty, racism, family stress, climate change. It was kind of appropriate time like the COVID pandemic, natural disasters, that all affects how our child grows and do we have access to food. So social determinants of health are so important that now we can actually get paid to code for those. And so we're going to, we'll talk about how to code for malnutrition, but also we want to add in the social determinants of health to help with the healthcare providers to help our social workers identify these problems. Coders in the hospital system can get the data from this and kind of also learn more about how we can help people. So again, the effective treatment involves underlying determine what the social determinants are and address them. And here are some of the other little resources that we have. And I'm going to go quickly over this. There's SNAP, there's the WIC, that's the supplemental nutrition for women, infants, and children. The SNAP is just the supplemental nutrition assistant program. That's what we used to call the food stamps and stuff. So the whole deal is if you think you've got a child that's in the hospital, you want to try to find out every factor that affects them for why they're not getting food or why they're not gaining weight. So now we've talked about you've got a child and you go, oh gosh, I'm in the clinic. You tried everything that you think you can. And now you go, I've failed outpatient treatment. I think they're malnourished. Well, how do we come up with the term malnutrition? Well, this is kind of, we've got the Academy of Nutrition. This is like Kelly, our nutritionist, her society, and then you've got the American Society for Parental and Enteral Nutrition came up with this definition, and it's all in the literature, and it's pretty simple. Malnutrition or undernutrition is an imbalance between nutrient requirements and intake resulting in the cumulative effects of deficits of energy, protein, and micronutrients that negatively affect growth development on relative outcomes. So now here we have a real term, a real diagnosis, and a real terminology that we want to use. So we're going to say malnutrition is what we want to document in the chart. And it's so important for y'all as residents and as attendings to make sure we use the right documentation. So again, how do we determine if someone is malnourished? We look at growth charts, and then we look at growth percentiles, and we look at Z-scores and all that kind of good stuff. And this helps us identify children that have problems with growth. So this is just going to be a brief overview. Well, Lord, how do you even look at a growth chart? What is a Z-score? What is a height, age, and all that kind of good stuff? And this, just real quick, just to say, this is the cause. This is how we help identify. And there we go, accurate measurements by trained professionals. So again, you've got to make sure that you know exactly how you're getting the measurements, because, how many times do you get a kid that might be admitted to the hospital for failure to thrive, but then when you get the old records and you go, well, gosh, they're following a curve, or they're here for some other reason, and the pediatricians completely missed that they're falling off the curve and stuff. And so to get growth charts, they're only going to be accurate as good as your people are that are taking the measurements. And here you can see Stallworth and I trying to learn how to use how to measure and plot on the growth curve. it can be difficult. Here's Kelly also trying to help me learn how to do this as well. So you can see that we're using two different scales. And again, this is all just kind of going to be reviewed, but know that they're growth charts, and we use certain growth charts at different ages. So big words so far we've learned. Fatty we don't use. We know about malnutrition, and then we need to know growth charts. If you're less than 2, you use the World Health Organization growth charts. And then if you're 2 to 19, you use the CDC growth charts. And luckily for us, that's loaded into our EMR and that sort of stuff are the appropriate growth charts. But if you're in your private practice, or you had to go to the old school and buy paper charts and paper growth charts, you would have to know that I got to get the right growth charts for the right age. And it's just kind of weird. The World Health does the ones less than 2, and the CDC does the ones greater than 2. And then, of course, you want to also realize that, gosh, if you have a special population of children that might have special needs, they might have special growth charts as well. I'm doing the Down syndrome clinic today, and so we have Down syndrome growth charts that we use. There are Turner syndrome growth charts. There are Noonan syndromes. I think those are the main ones they ask about, but just be aware that on test questions, they might say that, gosh, certain populations might have their own growth charts, and do know that there's certain ages you use different ones. So these are our infant ones, and these are done by the World Health. And again, you can see at the bottom corner, that's from birth and up to 2 years of age. We want to use these growth charts. Again, it's for boys and girls. And then if you're 2 to 20 years of age, you use the CDC growth charts. And again, there's your weight and stature, and there's the 2 years up to 20 years old. And again, this is already chosen for you, like in our clinic and that sort of stuff. And in private practice, you want to make sure you get these growth charts to give you the right score. So then we're going to plot these numbers, and we're going to real quick talk about how you get the numbers, and then you calculate Z-scores. And I didn't even know what Z-scores were when I was a resident way back when, but Z-scores are usually now calculated for us, but they are a unit of standard deviation from the normal range. So this is kind of helps you decide, well, how far off are they from what's normal? A statistical measure that tells how a single data point compares with normative data. Now, Z-scores, like we said, for us are already calculated, but there are different tools that you can use. What is that? PD tools? I don't know how to say that word. Pediatric tools, and this is like a example where you put the gestational age and their weight, circumference, and length, and down at the bottom, you can see where the percentiles and their Z-score would be. And you can see like a Z-score of 0.12, 0.18, or minus 0.011. So what all does that mean? So this is how we then classify malnutrition. And I think Dr. Edwards has probably shown all of y'all this growth, this chart. If you had to learn one thing from this talk, you would learn this chart. So now when we don't say failure to thrive, we say malnutrition, and we're talking about protein calorie, this meaning that we're talking about like inadequate calories. We then can classify it as mild, moderate, and severe. And it depends on how many data points that you have, whether you can, how you classify it. So again, the most easiest thing for me to remember is like the Z-scores, because again, I'm simple and that's easy. And you can look at here and go, gosh, mild malnutrition. You can look down there, and it talks about the weight gain velocity. It talks about weight loss. And then there's your Z-score, 1 to 1.9. That's mild. Then moderate malnutrition is going to be consist of Z-scores of 2 to 2.9. And then severe is going to be, minus 2 to minus 3. Okay. So that's going to be Z-scores. They're also taught, again, for each one, you can talk about the velocity, 25% of norm versus your weight loss. But again, just read each one of those. But the easiest one is to kind of look at your Z-score and then put it into mild, moderate, or severe. You know, the more negative, the more severe protein calorie malnutrition. And again, there's lots of different growth. There's lots of different classifications. And I think this is from Dr. Norton. They're all, Dr. Gambrell has all these different types of like Waterloo Criteria, and this talks about acute malnutrition versus chronic. And most people talk about 3 months for acute versus chronic, but you can see the formula at the bottom. And then there's the Gomez classification. There's another formula at the end. And then let's see, McLaurin criteria. So all of these are just different formulas to help you say, do we have a problem? And again, this is the most common one: malnutrition, decline of 1 Z-score, moderate decline of 2 Z-scores, and severe decline of 3 Z-scores. And again, there are other ways to talk about it, but that's usually the easiest. So in your chart, I mean, in your notes, when we admit failure to thrive, we shouldn't say failure to thrive. We will say severe protein calorie malnutrition, or moderate, or mild. Hopefully we won't be saying mild, because that's not, we're going to talk about when do you admit to the hospital. So those are 3 characteristics. And here are the codes. So mild, moderate, severe. And again, you don't have to memorize this, but know that these are ICD-10 codes. If you document failure to thrive, you're not going to get paid. And then here's your social determinants of health that you want to add on to there, that can also help you get more money and more code, and also helps social workers and people identify problems. So I think Dr. Van Brell had mentioned to us and to our partners about Z codes, and Z codes are like Z62 and Z63. Just know these are codes that help determine social determinants. And like, I think Z62, I have written down like inadequate parental supervision, history of abuse or history of neglect in childhood. So you can add, if you've heard it, if there's a history that, gosh, mom forgot to feed the child, or there's no food in the house, you can add Z-score to the malnutrition. Or Z62 as problems related to upbringing, other problems related to primary support around family circumstances. So if dad went to jail and there's family stressors and things like that, you can now code Z63. So again, the big important thing is coding the right code and using the right terminology. All right. Real quick, again, back to the growth charts. How do we measure? So less than 2 years of age, we talk about how long you are, versus greater than 2 years of age, we talk about how tall you are, right? So supine length for less than 2, so that's when you're going to be laying you down, and that's when you saw me and Stallworth on the scale in the clinic. And then if you're greater than 2, you're going to stand up with your back of your head up against the wall, and all this kind of upward pressure. And you can imagine this looks easy and looks kind of stupid that we're even talking about it, but get back there and try to do this with an infant and with a 4-year-old, and you will go, oh my God, it's a nightmare. And you will realize that, gosh, again, trained professionals, people that do this over and over and over again, will get better numbers. You can imagine doing that length right there. Lord, you could be off so much, and you could be admitting kids that don't need to be admitted, or you could be missing problems because you're inaccurately measuring. So again, it's really important. So there's the supine, there's the standing. We always like to do with minimal clothing. Take your shoes off. BMI, we know how to calculate the BMI. We don't start that till 2 years of age. So BMI, just remember, 2 years of age. Head circumference, we do that every time they come in for a well child up to 3 years of age. And again, head circumference, you measure around the head, but you have to measure the right part of the head. And that means 1 to 2 centimeters above the glabella anteriorly. And then you go all the way around to the most prominent part of the back of the head, occiput posteriorly. So again, you can do the tape measure around the head and get a completely wrong measurement unless you know what you're doing. All right, so just remember, 2 years of age, less than that, how do we measure versus standing up, greater than 2, and then head circumference and BMIs or other markers. These are just little test questions that people want you to know on tests just to memorize. Your head circumference, usually the average one I think is written down there somewhere 37 or 35 centimeters. Just remember that's average. So on a test question, if they gave you a kid, the head circumference was like 20 something, you would say, hey, gosh, that head's probably small to me. And then your head circumference increases about 1 centimeter per month during the first year of life. And then let's see, the average newborn weight, I'm not sure if you have to really know that, or the average length, but there it is, 20 inches and 3.5 kgs. This is a big slide about, we always hear about the 20 grams per day. So that's about how you want to infant weight gain. And this talks about up to 30 grams for the first 3 months, and then it stabilizes. And there's your 20 grams a day per day for the first year of life. And that's where you'll hear Kelly talk about, well, gosh, when she does, how much have they gained over the time they've been in the hospital? And you'll say the patient was up to 27 grams on an average every day. So that's kind of how she comes up with that 20 grams. And then everybody knows that you double your birth by 6 months and triple it by 12 months. Those are just things that you learn in medical school. And then of course, premature babies, we need to use the corrected growth charts, and you correct them up till they're about 2.5 to 3 years of age. And now most of our EMRs, automatically do that for us. And again, this is how much average weight gain, 10 kgs for the first year, 20 kgs, 5 to 10 years, 30. But for me, the big thing would be 20 grams per day for the first year of life. And then again, here's just another chart that's talking about the average weight gain. Again, 20 to 30 is what you're going to see on the test question. And then you talk about height velocity, like what is the normal rate of increase for height over time? And the magic test question is 6 centimeters. So you want to go, gosh, every year, hopefully you should grow about 6 centimeters on average. So again, these are just basic data points that they might throw out on a test question. So 6 centimeters is the normal height velocity. 35 is average head circumference. 20 grams is the normal weight of what you grow for a day. So just simple stuff. When you're looking at a growth chart, we know how to, you obviously put their weight and their height, you know how to put that, but you also want to know how to calculate the height age. And again, the height age is just the age, I had a picture, it's just the age at which the height of the child is at the 50th percentile. And that's just where you plot them on the growth curve, and then you draw a line all the way across to the 50th percentile, and then drop it down, and that gives you your height age. So if a child is 3 years old and they're at the 2nd percentile, and then you draw the line all the way across to the 50th percentile, you'll see, gosh, they might be 2 years old, but their height age is 1. So then you've got a problem if their height age is less than their chronological age. So these are all things, just how to use growth charts. And then mid-parental height is another formula. And this is for, you have different formulas for girls and boys. And this is your target heights. And again, if you notice that a kid is short, it doesn't necessarily mean that they have a growth problem. But again, it clues you into, oh gosh, let me look at all their parameters and say, do I have a problem? And just memorize this formula. It's mother's height in centimeter plus father's height minus 13 divided by 2, and then you add 13 for the boy. Again, just memorize that. But it's a good idea to say, this is the mid-parental height. Do you have a problem? It's a kind of a way to say, I think I need to look more into this and look at all 3 parameters. So now you've in the clinic, you've done all your documentation, you've done your growth charts, you've plotted them on the growth curve, and you go, oh crap, I've got a problem with growth. Is it malnutrition? Yes. And is it one of these 3 etiologies? Inadequate caloric intake, inadequate absorption, increased metabolic demand. And so then here we go. And again, it's very common sense that if we don't have enough calories, we're going to lose weight. And again, these are just easy, simple examples of that formula evolution. That's probably the most common one, is that parents inappropriately feed and they don't give enough calories, or they mix it inappropriately. So again, later on, we'll talk about the workup, how you've got to take a good diet history. Food insecurity, there's not food in the house, or breastfeeding. This is very common that mother thinks that her milk is in, and actually she's only pumping 1 ounce, a half an ounce. So again, neglect, maternal depression, that's why it's so important to do postpartum depression screens. And again, oral aversion, we see that a lot of our young kids that develop oral aversion, a lot of autistic kids are on the spectrum will have oral aversion. And then of course, any kind of GI anomaly or abnormality can cause you to vomit and lose weight. And that's going to be like reflux or malrotation. So those are all the most common examples that we would find when we put in the hospital. And again, the number one is going to be probably due to inadequate calories, not all this other stuff down at below. And then malabsorption means, okay, gosh, yeah, they're taking the calories, but they're just not absorbing them. So that's when you're losing it, like due to cystic fibrosis or liver disease or celiac disease, protein insensitive. So that's kind of another big issue. And then, or you have increased demand. That's when you have the heart disease, chronic cardiac, renal, and endocrine disease. If you're syndromic, Down syndrome kids, Russell Silver, Stallworth loves that one. Congenital infections, these kids have trouble gaining weight at birth. And so it's kind of interesting that Down syndrome kids will have trouble gaining weight when they're born early, but then as they get older, they have trouble with obesity as they get as an adult. But so you have to kind of find, once you identify that we have a problem, you want to put it into these 3 categories. Now, most of the kind of big take-home point is most of the diagnostic and evaluations can be performed on an outpatient basis. So hopefully, most of our residents and our that go out to practice in the real world, they are doing this all behind the scenes. So when they call y'all for an admission, hopefully they've done all of this and have gone through all of this first, that instead of just you'd hate to admit a kid and for y'all to walk in and go, mom's mixing the formula wrong. And that's what happens all the time. But the pediatrician as an outpatient should have picked up on that before, right? So a careful history and physical, careful diet history. And again, we could talk for days about all of that. How do you mix it? When do you give it? How often are you feeding? Again, then you want to use your growth charts. You want to calculate the mid-parental height. You want to find out their height age and their height velocity. Bone age is another thing. You can use hemiskeletons and x-rays, depending on your age. And then you have PT, OT, and speech. All of that can be done in your office. We have social workers that help them. We identify the social determinants of health and kind of help them go, okay, gosh, they need help paying their electric bill, or they need transportation to get to the WIC office. So those are all things that are so important to help outpatient malnutrition. Now, these are all the tests. And of course, Stallworth loves to talk about healthcare value. And Dr. Gambrill also talks about this as well. We have kind of like the first tier workup, and here's some of the labs. This is kind of what I consider first tier: CBC, CMP, UA, SED-rate. Not always do we do chest x-ray and thyroids and celiacs, but at least that's kind of like our first tier. And a lot of this can be done, you can do that as an outpatient. But again, if you come into the hospital, that's kind of what we'll start with. You might start with these as an outpatient, try some strategies. Then if they fail, you might repeat them again to see if anything's changed. Again, this is where you investigate more. So when they come in the hospital, you're going to go, gosh, if you have lots of diarrhea, you might do stool studies. If you're thinking about CF, fecal fat, and fecal elastase. If you're going about, gosh, you've had lots of staph infections and lots of or parasitic infections, and then you're going to go, oh, is it an immune globulin problem? Or you've got an inborn error metabolism problem. Or if you've got aspiration of all consistencies, then you need to think about your CNS and like, oh, let's get an MRI of the brain. If you're sweating with feeds and turning blue, you got to go, oh gosh, is this the heart? If you've got, lived in an old home and eating blinds and all that kind of good stuff. You think about exposures. Again, so these are all things that can be done as an outpatient, but we also look at them as an inpatient as well. All right, so now, when do we admit? And the test question is usually going to be moderate to severe malnutrition. So really, you want that moderate to severe, and you want a failed kind of outpatient treatment is when you admit. And again, kids or with moderate dehydration, or just like our kid that we had not too long ago with the horrible skin and serious MSSA staph infection, that kid was admitted for a combination of these three. They were dehydrated, they were septic, and they had severe malnutrition. And again, all this you admit when outpatient management has failed, or sometimes we admit if we just think there's neglect. And so sometimes you don't wait to fail outpatient. If you just know, gosh, mom's on crack and dad's in jail and there's a crystal meth lab right next door, you're going to say, gosh, I'm going to go ahead and admit those kids because I'm worried that there's a DSS social work component. And then when to admit, not on a Friday afternoon. This nowadays, we're so busy that you can't really avoid that. But ideally is that you don't want to admit a Fair to Thrive on a Friday because you know you want speech to come, you want to watch them, observe them, you might get some studies for GIs and things like that. You don't have to, but again, nothing happens on the weekend, and this is always such a frustrating admission that, you know, ideally we talk about maybe on a Tuesday. You don't like a Friday afternoon. Mondays are crazy, so maybe a Tuesday would be a good idea. And again, it's something that sometimes you can schedule. All right. Again, here is the weight gain, 20 grams. I don't know how that got thrown in there again. Now, once they get in the hospital, so you determine I've got malnutrition, you plotted on the growth curves, you know all those numbers. Now, how do you treat them? The magic test question is you want to go 120 kcals for catch-up growth. Because normally we do 80 to 100 kcals per calorie per kg per day is to gain weight. But here you're going to go, you've got to catch up. So you're going to do the 120. And again, this is where we're so grateful that Kelly is here for us. It helps us do all this math. But this is what we have to know. So you want to do 120 kcals, and sometimes we fortify formulas. So everybody knows that normal formula is 20 kcals, but you can go up to 24. And again, we don't jump to that, but that's one of the things that we think about when we're working them up. Now, speech, nutrition, occupational, PT, those are things we use all the time. You don't necessarily have to use all of them, but most of our kids, if they're truly admitted for Fair to Thrive or malnutrition, it's always a good idea to have nutrition and speech come, maybe speechful Zerba feed. And then we like to talk about daily weights and calorie counts. And when we say daily weights, this is where I think it's now in order, but we used to have to write this down that you want to say butt naked on the same scale, right? And so that's so important that if you don't use the same scale, you're going to be skewed, right? And so now I think on the third floor, and the fourth floor gets this wrong so many times, that you want to use the same scale. They're numbered, and the tech is supposed to know, you know, when the tech does 3 days in a row, that tech should know I'm weighing this baby on the same scale. And you hope when that tech switches over to a new tech that they say this is the scale that happens. Does that happen all the time? No. And so all of a sudden you'll go, well, why in the heck did my baby all of a sudden lose weight? And it might be just because of the scales in the hospital. All right. Now then, sometimes people talk about, do you need to do enteral feeds? And what are enteral feeds? That just means that that's when you're going to put a tube in the GI tract to give them formula or to give them food. And so that can be an NG tube or TP tube. And so we don't jump to that, but many times that's kind of our answer to help give us a diagnosis or a clue as to what's going on. And then in some of the articles, very rarely do they talk about supplementing or giving you like, appetite stimulants, but cyproheptadine is what's that also called periactin that can stimulate appetite. So there is some evidence to say, okay, if you're going to use one of them, maybe consider that. So the big deal is get them in the hospital and try to make sure you're giving them enough calories to say, gosh, can they grow? And again, this is all important to talk about the the whole history and the physical and stuff. So if you're going to do enteral feeds, that's the best way to go. We talked about NG versus TP. TP means transpyloric, so that just bypasses the stomach. And one of the test questions is, when do you want to use an NG feed? So or enteral feeds. And this would be like if you've got disorders of suck or swallowing. So that's when speech comes by and goes, gosh, they have a discoordinated suck, their vocal cord dysfunction. Any of those reasons, you go, let me see if I put an NG tube in and they gain weight, then you've proven that everything else works great. It's just that upper airway anomaly that is the problem. Again, abnormal function of the GI tracts. If you have short bowel, Hirschsprungs, horrible reflux, these kids sometimes come into the hospital, not always, and you can place an NG tube and make them and help come up with the diagnosis and realize, gosh, they're gaining weight now. And again, kids that have terrible renal disease and heart disease, and they're, like our kids that have unrepaired heart defects, oftentimes before they get their heart fixed, we're many times admitting them to the hospital to put an NG tube just to kind of keep them growing or keep them alive, because their increased metabolic demands, that heart is pumping so fast that they just can't keep up with their nutritional demands. And again, chronic malnutrition, anorexia, these kids, oftentimes the answer on the test is drop the NG tube. Now, again, this can be problematic and traumatic to the family, and this is where you have to kind of gingerly say, hey, welcome to the hospital. This is going to be a mess. This can be a cluster, but we're in this together, and kind of talk about goals. But this is where these admissions can be the most frustrating, and you can get fired so easily because the parents are going, well, you're not doing anything, because oftentimes we aren't, other than watching. And then it can get confrontational when the nurses say that mother didn't feed, but then she has that nice journal that she wrote down, which is not true. So again, it's a lot of talking, a lot of history. But again, one of the easiest things to do is drop an NG tube, and that can give you kind of some answers. Okay. When do you not want to drop an NG tube? And again, this is talking about NG tube with feeds going through. And that would be obviously if you have a small bowel obstruction or peritonitis, bowel ischemia, you're vomiting your brains out. It's not going to help to put an NG tube with feeds going through it. Now, this is not talking about, NG to suction and that sort of stuff, which you would use for obstructions and things like that, or going to surgery. But again, just know contraindications to placing NG or TP tubes. All right. So now, what is the good thing about enteral feeds is what they want you to know on the test question is that it's much more physiologic and is preferred. And for any kid that has an intact gag and cough reflex and they have a normal GI tract, putting an NG tube down is the best. Now, if you have gastroparesis or a motility problem, or like you're aspirating all consistencies, then you might choose to go, okay, instead of NG, which means the tube into the stomach, you might place a transpyloric tube, which again bypasses the whole 9 yards. Again, and then this is where Kelly helps us do the math, and you start at a continuous rate. So that's the biggest deal, is to know when you drop an NG tube that you start at a continuous rate, and then you slowly advance it, and you can either increase the concentration or the rate. And this is where Kelly and y'all all have your different formulas, and this is how we decide whether they're gaining weight or not. So you don't just drop the NG tube and go straight to boluses. You would do continuous enteral feeds first. All right, advancing feeds, call Kelly. Again, this is all where we're kind of spoiled here because she helps us so much that she really does a lot for us. All right, last kind of, but not least, with inpatient management for Failure to Thrive is refeeding syndrome. And just recently, I think, we had that kid up there that Dr. Jones and GI was very concerned about refeeding. So what happens with that is that it can be fatal, of course, initially fatal. And This, most of the literature says it's most commonly associated with parental nutrition. So parental nutrition is nutrition through the IV, like TPN, but the real deal is more related to the degree of malnutrition rather than the route. So in other words, if you give it IV like TPN versus NG, it's not as important as how severely malnourished the kid is when they come in. So if they're severely chronically malnourished, you're going to go, oh my gosh, those are the kids that are really at a high risk for refeeding syndrome. And if you're worried about refeeding syndrome, the good idea is to start the feeds at very slow rate, and 20% is kind of like a good idea. And of course, Kelly is going to help us with this. We always give them thiamine. And then the test question is, oh my gosh, you got to do these labs very frequently. And kind of the deal is these kids have been, when they've been chronically malnourished, they've, they're now all breaking down their fats. And all of a sudden you give them all this carbohydrates and glucose and stuff, then that's causes insulin to pour in, and all of these electrolytes go into the cells. And so you have low potassium, low mag, and low phosphorus. And so the test question will be low phosphorus is what really kills them. And again, that's the hallmark of refeeding. So low potassium, low mag, low phosphorus, and the hypophosphatemia is, if you had to pick one, that's the one that's most deadly. All right, now what does this say? This is talking about, again, most of our kids are not going to go into refeeding syndrome. Usually a well kid who's just lost some weight is not going to have refeeding syndrome. But again, those with severe chronic are at the highest risk. And it's usually, some people say, between 4 and 7 days after you start the feeds, but it can last up to 2 weeks. And so if we're worried, you will see Kelly that she will start doing electrolytes at least twice a day. Sometimes we'll do Q4 to Q6. And a lot of these kids will be up in the PICU that they'll be so worried. And in fact, I think that was one of the kids we had not too long ago that I think was in the PICU. So things you would look for, obviously, if you have all this change in fluid and salt and stuff, so you might have fluid retention, cardiac failure. If your potassium goes low enough, you can have EKG changes. Again, the diaphragm's a muscle, so if that doesn't work, hypoxia, and then leads to respiratory failure. And again, the phosphorus is when you can go into a coma and seizures. And again, the magic number is like less than 1.5. And the PICU attendings can help you more about what's the magic number. We used to know what the magic number for ionized calcium is, but for phosphorus in the literature, it talks about 1.5 or lower. You're at really risk to have some serious CNS insult with refeeding syndrome. All right, we're almost done. So you've got them admitted. You've done your whole history. We've categorized them as malnourished, whether they're mild, moderate, severe. You drop the NG tubes if you need to, and you then decide, okay, when am I going to send them home? And usually what we like to do is, maybe have another swallow study, maybe they pass. You want to get the NG tube out. And one of the articles that I believe Dr. Norton and Dr. Edwards kind of always cites talks about 3 days without IV fluids or TPN. Now, Lord help us, we know that this is so variable. I mean, just last week, we sent a kid home that was losing weight. But again, social factors all kind of play into when you decide to send them home. But on a test question, you would say, gosh, I want to document good weight gain without IV fluids and with TPN. So you never like to say, okay, let's stop the TPN and send them home the next day. Again, you want to make sure all the social concerns are addressed. So this is where we might room in for a little bit. And we have family meetings, and sometimes DSS is involved. We might have safety plans. This is where Kelly, remember, she comes in and gives them the formula, and she gives them enough formula so that they can make their WIC appointment. Again, this is all things Kelly does, but yet this is written in the literature. We write down exactly how they should refeed, and then we give this to all their caregivers. So again, it's important to teach mom, but also if grandmother is the one who is the main caregiver, grandmother needs to know how to feed the child. Or grandmother also needs to be the one who comes up here and rooms in. And then you want all your follow-up appointments made prior to discharge. Again, we should be doing that for every kid. And then frequent weight checks. So again, you're going to it doesn't have to be perfect when you send them home, but again, you want to be going in the right direction. And then the rest of the workup can be done as an outpatient where you're following the weights. And another good idea is to talk about using the same scale. So just like in the hospital where we try to say butt naked on the same scale, a lot of times you don't want to get confused if you have a discharge weight in the hospital versus a weight in your office. So there'll be some differences there. So a lot of times what we will have to do is when you discharge the kid, they might go by their primary doctor and just jump on the scale just for a weight and then see them back a week later. So again, now you have the primary doctor scales, and then you can follow the trend on the same scale. And just like in the hospital, you want to use that same scale in the office. So you ideally would like to follow up with the same provider. All right, and this is, again, you want to have all this set up prior to discharge to have success. All right, so I think that's about it. So the big deal is that failure to thrive, just realize we don't like that term anymore. We talk about malnutrition, and that most common, that's a sign of undernutrition. We're talking about protein, calorie, not enough calories. And so we classify it mild, moderate, and severe. We do that using Z-scores, -1, -1 to 2, -3. And then we plot them on a growth curve. You have to know how to use the growth curves. What is the Z-score? What is the height age? If you're less than 2, you use the WHO ones. If you're greater than 2, you use the CDC. And then when do we admit? You already know that you kind of want to do a lot of this can be done as an outpatient, that the studies show that all of these tests kind of usually don't lead to the diagnosis. So there's new articles in hospital medicine saying, gosh, do we need to get CBCs and urines and SED rates on every kid that's admitted for failure to thrive? Maybe not. And then, of course, the psychosocial problems are the biggest and most important thing to address. And that's with, and again, determine the social determinants of health. You want to code for that as well. So there we go. I think we're done with 10 minutes left. And at least the few people I see are still awake. Merry Christmas. Tomorrow I'm doing immunization. So these are the most awful topics to do. And I'm a terrible speaker, but hopefully all the information is on the slides. And if you have any questions, you can ask me later, because don't even try to figure out how I'm going to chat and talk with y'all or whatever. Stop, share. I don't even know how to do this. All right. Thank y'all very much. Let's see.
Thank you, Dr. Hahn.
Thanks,
Thank
Dr. Hahn.
Goodbye. Oh, Jeremiah. Bye.